Meet all the colleagues online. So I'm going to talk about the next wave of cell therapy. We're going to focus on the solid tumor, especially the solid tumor that is they're common in the Gulf region. So overall, in the Gulf region, breast cancer, colorectal cancer, and thyroid cancer account for almost 40% of all the new cancer cases. Nearly 60% of patients are diagnosed before.
You are muted, Prof. Yes.
Okay.
Yeah.
Okay. All right.
Yeah. Go
So
ahead.
I'll,
Sorry.
I'll, I'll go back. Yeah. Sorry. We're going to talk about the next wave of cell therapy. Um, we're going to focus on solid tumors, especially the solid tumor that is most common in the Gulf region. Uh, the breast, colorectal, and the thyroid cancer accounts for almost 40% of new cancer cases in the Gulf region. And nearly 60% of patients are diagnosed before age 60. It just highlights the early onset challenge that we're facing global wise. Um, the cancer burden in the Gulf region is projected to increase by up to 70% by year 2040. This is a big challenge to the health system. We've been making advantage and in the not only chemotherapy but also targeted therapy, immunotherapy, and so on. In recent years, the cell therapy has been pretty successful in the hematological malignancy. That's the first wave. Now we are seeing the new wave of using cell therapy in solid tumor. However, in the solid tumor, it's more complicated than the heme malignancy because the antigen heterogeneity and escape, because the tumors are so smart, they have diverse cells, and sometimes they don't express a target antigen. So we're losing our target. The second is the tumor microenvironment. It can be more immunosuppressive in the solid tumor, so the cell therapy won't work well as in the heme malignancy. Uh, the third factor is the limited trafficking and infiltration because the solid tumor has the physical barrier that prevent T cells from reaching the tumor core. Okay. To overcome all these barriers, the new cell therapy using different approaches. One is to use the TCR T cells. Uh, this one, the mechanism is to use engineered T cell recognizing the intracellular tumor proteins that presented on the cell surface with the MHC presentation. In this way, can expand the range of the antigen target um, and lock a new series of targets that presented on the cell surface. The second approach is to use the tumor infiltrating lymphocytes because those lymphocytes already infiltrated the tumor, and we can take those lymphocytes ex vivo and expand them outside of the body, then reinfuse them into the patient. Because TILs, they're naturally polyclonal and there's a multi-specific antigen recognition, so it can reduce the risk of antigen escape. The third approach is use NK cells or CAR NK cells, leverages the innate cytotoxicity by NK cells. Um, and also, it doesn't have the restriction from the MHC presentation. It doesn't have it doesn't require prior sensitization. And also it has much less toxicity, with less risk of the CRS and ICANS. And it has the potential to offer patients this so-called off-the-shelf allogeneic product. So those are the three major new approach that we're using. Let's talk about some of the data in the CAR T cell approach in the solid tumor. For metastatic colorectal cancer, the GCC19 CAR T cell shows some very provocative results. Although it's only phase one, it does show a 50% overall response rate with meaningful improvement of the overall survival up to 26 months compared with a lower dose. So this is a curve. The one on the left-hand side shows the progression-free survival curve compared with two different dose level. The yellow one represents a lower dose. The green one represents the higher dose. You can see the progression-free survival is better with the higher dose. The one on the right-hand side shows the overall survival. With the higher dose, it's up to 26 months versus 13 months with the lower dose. This is a study using the Claudin 18.2 as a target for the CAR T cell, especially in the advanced gastric and the G-junction malignancy. This is the first randomized trial of CAR T in solid tumor, randomizing 100 patients in the CAR T cell therapy arm and around 52 patients in the traditional control arm using the physician's choice. You can see on this progression-free survival curve, the blue curve represents the traditional chemotherapy arm. The red curve is the cell therapy arm. They improved the progression-free survival from 1.77 months to 3.25 months with a p-value less than 0.0001. This is the overall survival curve. You can tell the cell therapy arm improved the overall survival from 5.5 months to almost 8 months with a significant p-value. So this is the first randomized CAR T cell trial in solid tumor. In ASCO 2024, there was another phase one trial using the GPC3 as a specific target in advanced hepatocellular carcinoma. This is a so-called armored autologous CAR T cell therapy with a negative TGFR beta receptor 2. So it can protect the cells from the negative immunosuppression impact from the TGF beta. So this is the waterfall graph showing 4 different dose level on the blue, green, brown, and the pink one. The pink one represents the highest dose level at dose level 4. You can see overall response rate is 56%. At the higher dose, the dose level 4, the response rate is up to 75%. And the disease control rate is 91% overall. So very impressive data for a phase one trial. You can see this response tend to be durable. With the 9 months follow-up, the duration of response is 7.36 months. So very impressive data for phase one. So that's for CAR T. Let's take a look at some new data in the TILs. just in the ASCO 2025, um, there's a data presented for GT101 autologous TIL therapy in metastatic cervical cancer. There are about 11 patients presented. Overall response rate is 45%, with a 9% CR and a 36% PR rate. Overall, the disease control rate is 90.9%. Also in ASCO 2025, there's another phase 1 study using TIL in the advanced liver cancer. Although there are only 2 cases, but you can see the overall response rate is 50% with disease control 100%. Still very a premature result. We need to see more cases. So this slides just summarize some landmark approvals. The TIL therapy, the FDA already approved the lifileucel for unresected or metastatic melanoma with a response rate of 31.5%. The TCR-T therapy, the FDA approved the aflibercept autocell for synovial sarcoma with overall response rate 39%. There's some phase 1 and phase 2 trial data in solid tumor, including the TCR approach for synovial sarcoma with different targets. The response rate is in the 40 to 50% range. For CAR T cell targeting GI malignancy using Claudin 18.2, there's another trial showing the response rate in the almost 40%. With the GD2 target for neuroblastoma, there's a trial showing the response rate in the 63%. So, overall, with the full potential cell therapy, we still need to overcome a lot of hurdles. The first one is the antigen escape, especially with the solid tumor. There's antigen heterogeneity we have to overcome because the tumor can stop expressing the target and escape from the target therapy. Second is the immunosuppressive tumor microenvironment. The tumor microenvironment can release signals that turn off or exhaust the infused cells. The third one is how to infiltrate the solid tumor, because physical and chemical barrier prevent therapeutic cells from reaching the site and from penetrating the whole tumor. The fourth one is limited cell persistence, because the cell you infuse can become exhausted and it can be eliminated by the tumor. So how to keep the persistent efficacy is a challenge. Also, the manufacturer complexity is also a barrier. With the autologous therapy, they're so complicated. It's time consuming. It can fail if the patient's cells are not good anymore, because a lot of patients already received multiple lines of therapy. Their immune system is already weakened. So the quality of the autologous cells are not good anymore. So there's a trend to push the harvesting the immune cells as early as possible in the treating process. No matter it's CAR T or TIL, we're moving, try to push this to the front line. The last one is the safety and the on-target off-tumor toxicity, because we want to attack the tumor and avoid the normal tissue. But for now, there's no perfect target. We're still seeing the toxicity from the cell therapy, especially in the CRS or ACAN. So those are the barriers we have to overcome. The primary challenge is durability. How long can this last? we're treating advanced target with the cell engineering. We can use AI-driven target discovery to identify some novel target. Okay, we can use multiple antigen as a target, so we can avoid this off-target, on-target off tumor toxicity. Uh, we can use some novel platforms utilizing the CAR-NK or CAR macrophage for unique mechanism of action and the safety profiles. The second is to overcome the tumor microenvironment. We can use armored CAR engineering cells to secrete cytokines like the interleukin 12 to resist the inhibitory signal, such as the TGF beta. In the previous case, with a negative TGF beta 2 receptor, you can protect the cells from getting this negative immune suppressive signal. We can also combine the therapies synergistically with other approach like the checkpoint inhibitors, chemotherapy or radiation therapy, um, use them to enhance the infiltration and the persistence of your cell therapy. Thirdly, we can improve cell fitness uh, and the accessibility. For example, to use allogeneic off-the-shelf product using healthy donor cells, such as the iPSC, to create more robust, readily available therapies. We can use the CRISPR technology to enhance cell memory, phenotype, and also metabolomic resilience to prevent exhaustion. Uh, in practical, how to bring this to the bedside, there are two major challenges. One is the economic factor. Money is the cost is always the issue. The second is the safety issue. For the cost, the high upfront cost more than 400K US dollar per patient is a challenge. I think how to uh, make this available
صورة
in your region.
ما أسمع فيها شيء بس
Several
عشان
different
أسمع المنزل
approach
عندي
we
هذا.
can consider. For example, the value-based healthcare shifting focus from the volume to the patient outcomes. And you can manage the entry agreement, for example, implementing the outcome-based or risk-sharing payment models to establish this dedicated health technology assessment unit for evidence-informed reimbursement decision. For the safety issue, how to manage the cytokine releasing syndrome or the ICANS. I think number one is to standardize the guideline. We can adopt the ASCO guideline for the consensus. Also, to target the intervention, to use to see tocilizumab very promptly for the more grade 2 above CRS, and use the steroids for the ICANS. And also a multidisciplinary team is essential to manage this. We not only use, the oncology, but we need the neurology, we need the critical care physicians to work as a team to take care of patients. Another thing we need to communicate better to the patient is, to show them the realistic expectation and guide their decision making, because this is still largely a investigational approach for solid tumor. It's not like in the heme malignancy that is already a mature, very successful approach. The efficacy is not guaranteed. The response rate is high. However, there's variable response, and also it's overall lower than in the heme malignancy. And also the durability is also something that uncertain. It has unique risk for example, CRS and ICANS, those are the risks have to present well with your patient. Also, the access is complex and limited. For example, the patient has to be eligible for trials, and also the manufacture process also takes weeks to complete. The treatment is only available at selected institutions. Um, so those are the information we need to communicate well with our patients. Uh, you know, with all the hurdles and difficulties, but I think the overall future is bright. I think in the next 5 to 10 years, we can probably see the car and K and also off-the-shelf product that are being available. So that will benefit more patients and make the process faster and cost less. And I anticipate that the approval, the regulatory approach will work more efficiently to approve more product for our patient, especially by using the CRISPR-based technology and all those molecular method to enhance the persistence to make the overcome the tumor microenvironment inhibitor effect, make our product more safe for the patients. So that would be the my expectation for cell therapy in the next 5 to 10 years. Um, I think it's very important to build a network like the hub and spoke model uh, to bring this therapy to the region, to the patient. Um, we can carry out patient identification, screening, and enrollment in the spoke sites, like in the satellite sites. We can do the apheresis, we can do the tumor tissue collection, and then transfer that to the hub center, where the GMP cell manufacture is carried out with quality control, with advanced clinical oversight and protocol management. Once the product is finished, it can be shipped back to the spoke sites for infusion and long-term follow-up. So I think this model optimizes the resource utilization, builds a regional capacity, and also enable more equitable access to transformative therapies. Uh, Let me compare the different regulatory approach in US versus China. In United States and Europe, this is a traditional FDA, EMA regulatory approach. It's robust, it's proven, it works, it offers a very solid system to ensure that we have safety data, we have definitive evidence for a broad approval. In China, there's a dual track system. It has the similar approach as in US or Europe, follow this government NMPA regulatory approach. But on the other hand, there's a hospital-based track using investigator-initiated trials that are approved by local government or ethnic committees. This is a more nimble approach. It can fosters rapid innovation and dramatic increase in early phase clinical trials. It allows for academic exploration. So that's what I see. There's a lot of new trials carried out in China because you know myself and my U.S. colleagues are pretty envy my Chinese colleagues because they have more options for their patients. That's the benefit of this dual track system. Um, at Arion, I'll give a brief introduction for what happened in Arion. We built a 4 GPM clean rooms 3 in grade B and 1 grade C. Overall about 2,000 meters squared. We have 1 quality control laboratory and 5 R&D labs to support the whole system. And the facility is already operating in the past 6 months, and we're building up our team. We plan to have a 50 people team to work on this. And also, all this GMP clean room is on site in the hospital, right next door to our outpatient clinic and the inpatient floors. And we have our multi-discipline team on site for cell therapy. We have all the specialty team on site with the critical care team support. So it's a very unique setting. Even in Beijing, I haven't seen any hospital with this kind of setting. So it's very unique. It's a good setting for not only research, but also for patient care. It's very convenient. We can get the tissue in the OR, send it to the cell therapy team just right next building, have everything done on site without all this cold chain transportation issue. Yeah. So we've been working with different strategic partners, including the Peking University Cancer Hospital. We carry out 1 CAR T cell therapy program with lymphoma already. And also we're working with different companies using CAR T, such as the CD19, CD20 dual target, EGFR, and the GPC3 CAR T in solid tumor. Meantime, we put a lot of efforts in TIL therapy because to me, I think TIL has the most evidence in solid tumor. It's very promising. So we're working with different companies, including the product of GT101, GT307, and the BST02. We're carrying out a lot of trials, especially the IIT clinical studies. So, overall, I think in the Gulf region, there's an increasing tumor burden, not only in your region, but I think it's global wise, we're seeing the same trend that demand a new therapeutic paradigm. And I think fortunately, we have this technology improvement. We're catching up this next wave of cell therapy, including the TCR-T, TIL, and NK cells. And hopefully, we'll get this to the patient. We can, get through all these, hurdles we mentioned about and provide better care for our patients. So I'll stop here. Any questions, I'll be happy to answer.
Thank you so much, Prof. It was really comprehensive, great, detailed, deep